Well, it's a real delight to be here and to see sort of a massive group who really are our therapists in Norfolk and the local area. And it's great to see a group of people here sort of together. And I think that I'm here partly from the University of East Anglia. I'm also a joint clinical director and clinical lead of youth services in the Trust. And we've been doing a lot of thinking really about how we work with young people in the Trust. And one of the things I'm here to talk about really is I've come from working with people with psychosis and first episode psychosis, but thinking about how we prevent and how we detect. And I think the more we've thought about that, the more that isn't so much a case of we have so many things of let's pass a case on to the Mental Health Trust, that's a severe case, we'll do it. It's really, really clear that you are the early detection service, you are the early intervention service. And if we're going to sort things out, it's about how we work together. We're one team. And the problems that you get with late detection and long durations of untreated psychosis and people getting is they go to one agency who says, that's too severe, that's not for me. They go to another one who says, that's not quite right, that doesn't quite reach our criteria. And what we really need is, actually, there's a fantastic weight of experience in this room. And actually what we need to do is add to each other's experience and work together as a team. So rather than create another mental health team for early intervention, it's a case of working. You are the early intervention team, and it's how we all work together and share our skills. So these sorts of opportunities, I think, are the way forward. And in a time when financial crises and things like that, actually, we have to work more efficiently. We have to work together. And that's really what the commissioners are saying to us too. So it's really, really great to be here. So I'm going to have a talk really about the story of research that we've been involved in early intervention. And just as I go through, sort of see where that fits into that story. And then end on a current trial we're currently working on that we're looking for referrals. But part of that is reaching out to you guys and working together. So you'll see that as the story unfolds. So the story goes, psychological intervention and prevention in early and prodromal psychosis should be targeting social disability. And the story of that is really, the focus has really been around people with psychotic symptoms and detecting them around those. And I'm starting to think more and more, actually it's about, yes, it's about early psychotic symptoms, but it's about whole comorbidity. It's our cases that don't have one disorder, they have depression, social anxiety, and social disability, and psychosis. They're the problematic cases. I'm speaking here as me, but I just want to make it really clear, actually, I work with several teams all round and teams here, so one is always speaking on behalf of everything. The first story is about psychosis. So I'm saying about early intervention, who should you refer on to a secondary mental health case? Well, people with first episode psychosis. So if people really have florid hallucinations, florid delusions, I think there is a real case for a proper first episode early intervention service. And the piece of research which I'm most proud of is this it was just historical control. It was tracking the course of people with psychosis over a period of 10 years between 1998 and 2007. And the reason that we started in early psychosis, this was before 2003 when first episode psychosis services came out. When I was looking at it, it was terrible. These were young cases of psychosis, and only 15% of them, before the of early intervention services, were making a social recovery at 2 years. And this included people who were breaking down at university, in A-levels. Their lives were completely damaged for ongoing lives. After we put together an early intervention team with supported employment and integrated intervention team, we're now pushing 50–60% making recovery, and with the National EDIE project, which we're looking at 1,000 cases across the UK, it's around that level. So if you think that 15% to 50–60% is a massive change, then, and that's clearly, we tried it with a partial EI service. It was really having a full integrated service. And the NICE guidelines now have looked at the evidence. Early intervention is recommended, reduces admissions and bed days and costs, improves social functioning. So yeah, there is good evidence for this. So that's really where we need to pass on. The question I had was that, well, you know, well, if it works with early psychosis, can you go a bit earlier? You know, can we detect? Well, you know, and the other thing is that those cases that don't do so well, if you look at them, the ones that don't do so well, that other 40%, they don't do so well because they're chronic patients by the time they get to us. So they've had chronic social disability, chronic disorder for about 8 years sometimes before they've got to us. So there's a real case. How do we look in? How do we detect? How do we get into that group? So that's the story I want to share with you. But actually, I'll get to the conclusion of that, is that we work together. You know, it isn't about referring all those cases to us as well. It's how we work together on them. So, you know, this is just the social disability gap. Again, the symptoms. So, you know, being in mental health services, we get overly focused on symptoms. We diagnose everything on symptoms. But actually, symptoms in first episode psychosis go up and down. And first episode psychosis is that blip. And actually, people recover from the first episode psychosis within about 12 weeks with decent treatment. And then they have lowish level symptoms. It's the social disability that remains continuously poor. But again, you can see, and we've known this since the 70s, that actually the social disability starts accruing way before you get a first episode psychosis. And as I was saying, the evidence that we've got with the difficult cases who really remain socially disabled, it's because they've had social disability for some years before they get psychotic. And often chronic depression, chronic social anxiety, other kinds of problems. So who am I talking about? We're really talking about kids with very low levels of activity, amotivation, depression and loss of hope. They've almost completely given up. The low levels of activity really you can think of as avoidance, actually. I think that they're very frightened, very anxious people, they're paranoid people, they've just given up. It's a form of avoidance. Drug abuse, social anxiety, I think comes out again and again. Early signs of social anxiety, again, withdrawal. It's social anxiety and paranoia that's driving the avoidance. And then schizotypal at-risk mental state, not quite psychotic symptoms, but on that continuum, anomalous experiences, voices, and paranoia. So that's the kind of clinical picture. So what I'm going to do is quickly whiz through, you know, how do we assess, how do we look at, how are we going to pick up early signs of social recovery? What are we looking for? When do they start occurring? What are the predictors of delayed social recovery, and how might we intervene early? So I'm going to describe some data that we've got from several studies. The time use survey, which is an epidemiological study of time use in the UK, for which we can get matched young people. We've got about 6,000 of those. The EDIE RCT of CBT in at-risk mental states, which was done across, was about 300 people from that. There's 1,000 people from the National Lead and UK Evaluation of Early Intervention Service. And then studies we've done on more early, more chronic cases, the ISREP study. How we're looking at time use is that, again, if we're thinking about time use and recovery, everybody is focused on work, either work or education. The trouble with work and education is often you can get people who are signed on at work or at school and not going. You've actually got to look at attendance with that. So numbers of hours actually doing things, because you can have lots of people, I mean, you know, everybody knows kids at school, they're registered at school, but they're not going to school. But also, you know, social recovery doesn't just mean work, you know, and I'm a parent of an adolescent, and actually, how do I measure if the kids are doing well? It's whether they're going out with their mates, if they're going to the cinema, if they're going to football, if they're doing, you know, it's the whole range and plethora of well-being is measured around that. So this is a detailed interview looking at work, education, voluntary work, childcare, but also leisure, sports activities. It's well-being in terms of activity. That's what we're looking at, so the figures. So we can compare weekly hours in structured activity across samples of individuals, non-clinical sample, at-risk mental state, first episode psychosis. So this is a comparison of what people are doing, and this is young people in the normal population, aged match control, and you can see that they're doing 60 to 70 hours mean activity. I mean, busy people who've got lives and whatever can be up to 100. The interesting thing is you've got your more, you know, people 8 years after a first episode psychotic episode, the ISREP study and first episode psychosis there. you can see really much, much, much lower levels of activity, really not doing very much. But the interesting thing there with the EDIE cases is these are people before psychosis. They're also, you can see, much closer to the chronic groups than they are to the other groups. It starts early. This pattern of negative avoidance starts early. And that's the clinical picture, that they get stuck in a lifestyle of withdrawal very early on. And if it has become 6 years, even if you put a first episode psychosis case, service, it's too stuck, it's too much a pattern to do very much about. You then look within the EDIE subgroups, within the total, so these are young people with at-risk mental states that we're picking up for having, you know, mild hallucinations, anomalous experience, paranoia. Yeah, the mean is 30, but if you then look at those not in education, employment and training, these are kids doing a mean of 12. So that's a mean of 12. You've got kids doing less than 8 hours, not going out the house, basically, stuck in the house for 6 hours, you know, not doing anything outside the house, structured, for more than 6 hours a week. That is really, really very, very withdrawn and very stuck. That's a very damaging place to be. And I think there's an interaction between that stuck social withdrawal and being depressed. It's one thing being depressed and neurotic depressed if you've got a job, if you're going to work, if things are going wrong in your life. If you're stuck and you've got nothing going on in your life and you're depressed, there's no way out. And also the social anxiety that's there, you're never going to escape from that. So the withdrawal kicks in with these other problems. So the conclusions from these studies, individuals with psychosis spend specifically less than hours per week engaged in structured activity. But this active reduction activity begins before the onset of psychosis and clearly present in the at-risk mental state stage. What predicts social recovery problems? So these are the ones who don't recover from first episode psychosis, being male, younger age of onset, poor premorbid adjustment in adolescence. And again, we've known this. It was just so obvious. We've known poor premorbid in adjustments in the 70s, but we don't. We'll take questions later. Structured activity is anything outside the house. Doing anything constructive, like playing football, like going out, like going shopping, like doing anything. Economic activity is work and education. There's a whole list of things, but it includes hobbies, but anything with another person, a social contact outside the house would include. Long duration of untreated psychosis, so the longer that you've had your psychosis before you enter a first episode psychosis. So again, this thing about detection is quite important. If you're working with first episode psychosis patients, do quickly get them in. The longer that they're untreated, the worse it is. Baseline negative symptoms. So we may be able to identify those at risk and early, but how? Well, the major study that we've done on this, which we've completed, is the EDIE study, Early Detection, Intervention, Evaluation of People at Risk of Psychosis, a randomized controlled treatment trial. And for those who are interested, it was in the BMJ in 2012. Tony Morrison in Manchester was the chief investigator. The aim of this was to see whether cognitive therapy would be effective in preventing the worsening of emerging psychotic symptoms experienced by help-seeking young people deemed to be at risk for serious conditions such as psychosis, schizophrenia. And they were deemed of being at risk because of criteria on the presence of prodromal symptoms. So they had anomalous experiences, strange experiences, or paranoia, or some degree of hallucinations. Not quite psychotic, but if they had those, they could come into the study. And we had 288 participants. We were expecting a transition rate based on all the other studies of about 30–40%. Actually, we only got, as a result of both arms, a transition rate of about 8%. What we found was that the severity of psychotic symptoms was significantly reduced in cognitive therapy worked on the psychotic symptoms itself, but the main take-home message I want you to take is the group who, this treatment trial had two arms. We gave cognitive therapy to one arm, and then in both arms, what we gave them was structured monitoring. We assessed them very carefully. We then monitored them very closely over the period. And during that monitoring, we gave them guided risk management We gave them signposting, we gave them supportive help in both arms, and then one arm we gave an extra therapy, and there was also some degree of contact with other services in both arms. So the issue with that was that the group who received supportive risk management and monitoring also improved on many clinical dimensions, nearly to the same degree as those who got cognitive therapy. So the interesting thing about doing this, and it's consistent with the whole of the ultra-high risk population, there's a positive story from this, is quite a positive story. These were cases, actually I'll just go to tell some clinical stories about this. When I first started doing EDIE, it frightened the living daylights out of me, because I've been working with first episode psychosis, which are difficult, chronic patients, they're quite suicidal, they're quite difficult, they're psychotic. When I started working with these patients, it frightened the living daylights out of me. These were in primary care, they were looking for help, but they were suicidal, they had degrees of risk, quite high risk of others. They were hitting people on the street, they were hitting their parents. They were quite high levels towards the end of a risk factor, and they were comorbid. And when I started this study, actually, I felt quite hopeless. I thought this was very disorganized. These are out there in primary care. So my expectation was not that this would be a great success across the thing. It would be, my God, what am I doing? How can I manage these cases out in the community? And I think they're the cases that you're seeing coming through your doors. The surprising clinical implications for me from EDIE was there was a natural recovery pathway in both arms. And I don't think it was because we were doing nothing. It was because of the supported case management, the structure, the sort of guided self-help, risk management and things like that. So the surprising clinical implication from EDIE is that many, even quite severe youth cases with mixed symptoms and psychotic-like features recover with good structured supportive therapy. And I think Dickon will be talking about the types of things that could go there. Structured risk management and monitoring provided. That actually, if you do that, the key thing, I think it resonated much with that thing of rapid intervention. It's actually, early intervention is just doing the right things early. If you do the right things, catch people early, give the family and them supportive work, guided risk management, making sure that people aren't panicking about what's happening, stabilizing it, even though it peaks and it looks quite acute, unlike psychosis, actually it recovers quite quickly and it stabilizes. If you do nothing, it gets worse and worse and worse. But that's your intervention. The other story with that is that those who have both, so if they've just got flashes of paranoia and hallucinations and things, they're not necessarily as risk of psychosis as we think. If you do the right things, they'll recover. The ones that we really need to look at are those who have both at-risk mental states and chronic social disability. The indications are those less likely to recover and maybe at risk of more longer-term disability. Possibly, this group might benefit from a more intensive intervention, more like the early intervention, combining cognitive therapy with social recovery techniques. But that's a question. It's a research question. So who are we looking at now? So I think those cases that I just talked about, who frighten the living daylights out of me, who you see, and I know from talking to Michael about Matt, you've got lots of those, very frightening, they're very complex, they look very, very difficult cases. We need to work together to manage those well and provide a decent intervention. And the EDIE study suggests if you do that, that's the intervention. And I think that we can do that successfully well. There's another group, this group, which I think actually we may have to do something more with. So cases at risk of long-term social recovery, severe mental health problems. Who are we looking at? Low activities, not in education, employment and training, who've also got a complex comorbid mental health problem comprising depression, amotivation, drug abuse, social anxiety, schizotypal symptoms, anomalous experiences, voices and paranoia. And it's interesting because it's the same thing as I was talking about before. It's the same picture. The ones who didn't recover from first episode psychosis, they don't, because it's the same picture as earlier on. It's not that something changed, it's that they've just been chronic all the way through. So it's those cases that we need to look for. What would we do with them? Well, I think we need a sort of new treatment which provides social opportunities, providing hope, positive future, positive self-esteem, while managing depression, social anxiety and paranoia, but combining that with assertive outreach, case management, supported employment, education techniques, and specific cognitive behavioural things. It's actually a combination between finding people social opportunities, but actually doing the therapy on the way. And it requires people also to step out of the clinic, work with them on buses going to things, and working, helping people to get active, combining the sort of therapy techniques with the more activity promotion techniques. And often we separate the two. We say, well, you go to the supported employment agency and you go to the therapy. And the trouble is that the two don't quite connect. You actually need to integrate the two very closely. And there's quite a lot of formulation and systemic formulation of the barriers to the recovery. Some of the recovery problems aren't so much about the individual, they're about the formulation of the system surrounding them. They're about people not offering opportunities and talking systemically with the family, with the education provider, with other people, creating opportunities for people. Fostering a self-image as a hero in an active struggle, instilling a positive sense of identity, which I think actually linked with the previous talk. It's accessing that other bit of the brain and getting people to think positively about themselves in the future. Specific goals and barriers, and then some sort of behavioural tests to establish a positive sense of identity while managing social anxiety and paranoia. Why might we think this work? Why we might think this work is because we did a trial with this kind of thing, with cases who hadn't really recovered from psychosis. So we did a trial of this sort of thing, a platform trial in 2009, using this sort of thing with cases that had come through first episode psychosis and hadn't made a recovery. And actually that trial was quite successful with certain groups of them, really showing what that shows is that they gained about, there was a difference in about 12 hours activity between the two groups. So there was a gain in activity and there were reductions in symptoms. It was a pilot study, it needs replicating, but it's the results of that study that shows that we might do it. So where are we now? We've now got funding, and HTA funding now, for a trial we're just starting called PRODIGY, Prevention of Long-Term Disability Amongst Young People with Enduring Psychological Difficulties, and it's a pilot stage of this trial. What we're going to do is try and provide this type of therapy at a much earlier stage, so not providing it right after people have been first episode psychosis, but try and pick up these cases we're particularly trying to develop links with people who are not in education, employment, training services, and look for those with mental health needs from that and pick them up through that. So providing this at a much earlier stage. The pilot phase of this trial is 100 in Norfolk and Manchester, but we're hoping to get funding for a full trial. If we successfully recruit in the early stage, I think we'll probably get funding for a full-scale trial. So it's a randomized controlled treatment arm. But it's importantly, going back to what I was saying, the control condition will be optimal treatment as usual. And as in EDIE, the aim is to ensure that those in the control arm will have good supportive psychotherapy, risk management and monitoring. So the key with this is to see, yes, it may be, but actually if we optimize the control arm, you'd be surprised. We may get benefits from that too. So the aim is to work with you guys in the control arm of this also to see if we can maximize the intervention of that. Because I quite like developing new therapies, but actually, if you don't need them, I'm not that worried. So what we'll try and do is maximize the control condition. Intervention will last for 9 months with assessments baseline 9 months 15th. And we're doing qualitative sub-studies to evaluate the intervention from the subjective perspectives of participants. So we're looking for 100, 50 here, 50 in East Anglia. I'd like to over-recruit. We can probably try and pilot our networking things on the back of this trial. But specifically for the trial, we're looking for young people 16 to 25, presenting with service with mental health problems and social disability. Social disability defined as less than 30 hours a week or less taking part in structured activity and having a complex mental health problem or at this mental state. How do you refer? Recruitment begins now, really, and continues through to January 14. If any young person you think might be suitable for the trial, just contact a member of any of us. You'll be asked to give the young person information sheet. But what we're trying to do with this trial is not just run it as a trial. What we're trying to do is back this trial up with what we're trying to do with a service about networking in with you. So there will be support and supervision. So when Tim's going out to work with these different agencies, what we're trying to do is provide support and supervision and adding in any expertise that we can deliver from the secondary mental health service as team working as part of that. So we're trying to sort of do the two things together, a sort of clinical strategy for the youth service and the trial together. So there's a variety of people around. So there's Tim, there's Rebecca, there's Joe Hodgkins, Bryony, and then there's me. So it looks promising. Okay, I'll finish there.